thank you everyone for joining the session today. That is drug-coated balloon in emerging technologies in the modern PCI. So looking, going forward with the DCB session, I would just like to, let you all know what Translumina is about. So we are committed to explore limitless possibilities, wherein a company solution with coronary interventions, wherein it was incorporated within 2000 and in presence of 50 plus countries, and Translumina has been certified with a great place to work with 5 global manufacturing facilities and 3 indigenous manufacturing facilities over here. And our R&D excellence is based at German Heart Center, wherein 8 strategic partnerships are there, and CE certified products with 10 years of clinical safety and efficacy data. So sharing about our manufacturing facilities, which is backward integrated as manufacturing facility in Germany, and one in the Dehradun as well. So this is our Transil, which is our Asia's largest laser cutting facility. So world's first company to create DES technologies with 10 years of safety and efficacy data on 2 stent platforms, that is Yukon Choice and Vivo SR, also available for a diabetic subset, CAC and ACS. So recently there has been an acquisition with Blue Medical that is based at Netherlands for one of our product that is a Protégé drug-coated balloon, which has its presence in 35 countries, and its R&D and manufacturing is based at Netherlands. And Protégé is EU MDR certified with patented drug application process. So as mentioned, Protégé is a paclitaxel coated coronary balloon dilatation catheter, which has its 3 unique technologies, that is unique drug application process, wherein minimal drug loss transition is there. And the second is wing seal technology, which is the patented technology, which says corrugation basically ensures effective drug delivery at the lesion site. And lastly, the multiple inflations, just because of unique drug coating application process and the wing seal technology, multiple inflations is possible, which actually makes available the release of drug up to 3 times with the same device. And Protégé is the world's first non-compliant DCB that Translumina has brought up with this. So today's session, I would like to thank you all again for joining it and sharing your, further we'll be sharing your, experiences with each other. I would like to introduce Professor Ruben Tranio, the head of the Department of Interventional Cardiology at Delta Hospital. And sir has been serving as the director of Department of Cardiological Medicine at Delta Hospital as well. Thank you, Shrikant, sir. Sir has been associated with Director and HOD of Cardiology at Sakra Hospital, Bangalore. Sir, I would request you to please take the session forward, sir.
Thank you. Thank you very much for the introduction. And I thank Dr. Ruben and all our esteemed speakers to have joined this meeting to share their insights and experiences and evidence that is available on the increasing use of drug-coated balloons in coronary intervention and how that is revolutionizing our practice of coronary interventions. And in our own hospital, the use of DCB has seen a significant jump in the last 1.5 years, and we have found that it has simplified therapies in fairly complex anatomical and clinical scenarios. So today we will hear from Dr. Ruben about his insights into emerging DCB technologies and also show challenging cases with Protégé DCB. Dr. Ruben, please.
Okay. Thank you very much for Translumina for this invitation, and it's an honor for me to share this session with my colleagues of India. I will share the screen. Can you see the screen? My topic for today is insight into emerging DCB technology and challenging case with Protégé DCB. The first question is, why use pharmacological balloons? And the answer is to preserve endothelial function. We know that the stent produces endothelial dysfunction. The endothelial dysfunction produces serious cardiac events such as myocardial infarction, fatal arrhythmia, or sudden death. This is a good example of endothelial dysfunction. The problem is in the distal segment treated, and when we treat with a stent, this distal segment, when we treat with stent, it has hypersensitivity in vasomotility. This hypersensitivity in vasomotility produces serious, very serious spasms in the distal part. Here you can see another example of our cath lab that we did a couple of months ago. What is the performance of the drug-eluting stent through the long term? The DS show a permanent increase of 2 to 3% per year in MACE. That is very, very, very important. In MACE during the 5 to 10 years after the implantation, and which is what happened with the DCB long term. The DCB stopped the incidence of events after the first year post-implantation, and then you can see a plateau of events, while the drug-eluting stent continued to increase these events. This is one of the principal reasons that we have to put a DCB. Of course, the paclitaxel is a drug of choice because it has large clinical evidence and several publications, more than 1,110 published studies, more than 25,000 documented patients in more than 20 countries. Protégé use paclitaxel. Is the unique drug application, is a windshield technology, and use the M3I technology. The M3I technology allows drug release up to 3 times with the same device when clinical is indicated. Here you can see the 3 times inflation in multiple locations, and this is effective because the tissue-bound paclitaxel dosage applied by the Protégé device is greater than the effective minimal optimal dosage. We use drug-coating balloon in different scenarios. One of the most frequent scenarios is intra-stent stenosis, but also we use in small vessel, high bleeding patients, bifurcation lesions, large vessel disease, and acute coronary syndrome. In the case of in-stent stenosis, this is a class 1 recommendation with level of evidence A. So this is a very strong indication. Which is the evidence of drug-coating balloon in stent stenosis and small vessels? Well, in DEBTalks, this is a great meta-analysis. The evidence in stent stenosis, it has a significant difference in 3 years target lesion revascularization rate in favor of drug-eluting stent, but there are numerical difference in the safety endpoints in favor of drug-coating balloon. On the other hand, the Andromeda is a meta-analysis for small vessels. It has significantly lower incidence of MACE in favor of drug-coating balloon, 18.5% versus 24%. In small vessel, we will focus in 3 important studies. One is the PEARL registry, is a registry paclitaxel coating balloon Protégé DCB in the novo and in-stent stenosis. The Transform-1 trial is a randomized controlled trial with paclitaxel coating balloon versus sirolimus coating balloon in the novo small vessels, and the reform study is the Biolimus coating balloon versus paclitaxel coating balloon in in-stent restenosis. You can see different application, different scenario. Let me see the study Transform 1. The Transform 1 is for de novo small vessel, and it compares sirolimus coating balloon versus paclitaxel coating balloon. The primary point is a 6-month angiographic net lumen gauge, and with sirolimus coating balloon, the lane loss was 0.32 millimeters versus paclitaxel, the lane loss was 0. And the opposite, the lane lumen enlargement was only 30% with sirolimus and 53% with paclitaxel. So we can say that the sirolimus coating balloon failed to achieve non-inferiority compared to paclitaxel coating balloon for angiographic net gain at 6 months. What happened with the drug coating balloon in stent restenosis? Okay, let's go to the reform study. The reform study is a randomized trial of drug coating balloon for in-stent restenosis. Compare Biolimus coating balloon versus paclitaxel coating balloon. The primary endpoint is in segment rates diameter stenosis at 6 months. The Biolimus, the stenosis observed was 43%, and with paclitaxel 31%. So the conclusion of the reform study is failed to demonstrate non-inferiority of the Biolimus coating balloon compared with the paclitaxel coating balloon in patients with stent restenosis. So with this two trials, the gold standard is the paclitaxel. The paclitaxel for the novo small vessels and the paclitaxel for in-stent restenosis with the reform trial. Now we will see the PEARL study. The PEARL study shows that the Protégé paclitaxel DCB is safe and effective for PCI of in-stent restenosis and de novo lesion. It includes more than 500 patients, high risk 500 patients. The results of this study at 2-year follow-up is in the novo lesion, the MACE was very low, 9.7%. The MACE in stent restenosis is 17%, comparing with the literature that is similar as the novo lesion, the MACE. The TLR was very low in low lesion, 2.9, and the TLR in stent restenosis is 11%, lower than the literature that is around 15%. Bailout stenting was required only in 3% of the cases. In conclusion, the use of Protégé paclitaxel DCB for PCI of in-stent restenosis and de novo lesions is safe and effective during the 2 years of follow-up. If we compare this study, the PEARL study, with Protégé and the Eastbourne study with sirolimus coating balloon, we can see at 1 year of follow-up no difference, but numerically has in favor of MACE in the novo lesion with paclitaxel, and also in the group of in-stent restenosis, numerica has in favor of paclitaxel for in-stent restenosis. But you must take into account that the key point of this, when you use DCB, is the optimal lesion preparation, optimal predilatation, and then you have option, and depend on the result, you can use DCB or you can use drug-eluting stents. So now, why DCB, why paclitaxel, and why Protégé? Why DCB? Because potential to reduce 2 to 3% year observed with drug-eluting stent-related MACE through the long term, avoid in-stent restenosis, improve outcomes in a specific subset, and hybrid approach is possible and beneficial. Why paclitaxel? Positive vessel remodeling with higher late lumen enlargement, quicker vessel healing and faster re-endothelization, apoptotic effect reduced toxicity, and high absorption into vessel wall. And why Protégé? Multiple inflation with effective minimal dosage M3I technology, unique coating paclitaxel applied within the folder, preventing loss prior inflation, Wincing technology ensuring better trackability and crossability, and the type wrapping prevent the balloon unfolding during the advance. So we have a similar thing and different thing in Argentina and India. The similar is the surface, but the difference is the population. And the same happened with DCB. It has similar anti-proliferative drug, but no the same again. There are no class effect between the drugs. So I will thank for you and will thank for your attention, and I will listen the next speaker. Thank you very much.
Thank you, Dr. Ruben, for that excellent summary about the use of paclitaxel-coated balloon in various scenarios, de novo to ISR to small vessel subset, and its comparison with the other drugs, sirolimus and biolimus. And we'll probably have discussions at the end of all presentation. Is that okay?
Yeah.
Absolutely, sir.
Yeah. So now I invite Dr. Kinjal Bhatt, Senior Interventional Cardiologist from Synergy Super Speciality Hospital, Rajkot. He's going to talk about, will DCB replace DES? So DCB data beyond ISR. So Dr. Kinjal.
Yeah. Good evening and thank you very much. Yeah.
Dr. Ruben has to stop sharing his screen.
Yes, I stop sharing.
Dr. Kinjal. Okay.
Yeah. Yes, I'm sharing my presentation. Lights are visible?
Yes.
Yeah. So, sir has nicely explained regarding DCB, the use of DCB in stent stenosis. So I will discuss briefly the use of DCB beyond the typical indication, that is stent stenosis.
Kinjal, sir, sorry to interrupt. Your voice is not properly audible, sir.
Now it is audible.
Better, yes, sir.
Yeah. So Dr. Rubin has nicely explained regarding the use of DCB in case of ISR. So I will briefly discuss the use of DCB beyond its typical indication, that is stent stenosis. So we all know that the drug-coated balloon is it will deliver the anti-proliferative drug. In this case, it is a paclitaxel, and it doesn't leave the permanent scaffold there. And purpose is that they reduce the risk of scaffold failure and treat the maximum lesions with the minimum stent. And most important is when the patients are at the risk of bleeding, or those who are at not risk of the bleeding, but they have future chance of bleeding, then we can avoid the long-term dual antiplatelet. So as per practice guideline, the DCBs are has proven its role in stent restenosis, but there are increasing number of cases where we can use it, basically in small coronary vessels, and when there are bifurcation lesions, then we can use it. So, what are the potential benefit of drug-coated balloon? We all know that we can use it in instant restenosis. It has a low 6-month late lumen loss, and we can use it in basically when a small coronary artery disease vessel where the stent vessels are as such that stent putting a stent was not feasible. So we can use it in de novo small vessel disease, where in case of a large vessel disease, right, we can still, the stent is a gold standard, but we can use it in basically a younger patient and who has to take dual antiplatelet for prolonged period of time. In that case, we can use it in large CAD patient. Bifurcation lesions, that we can treat the main vessel with the stent and side vessels with the drug-eluting balloon, drug-coated balloon. ACS, there are trials that shows that it has a similar 9-month or 2-year MACE and late lumen loss with compared to DES. High bleeding risk patient, basically elderly patient, we can use it. And diabetic patient is typically is a diffuse disease, and the vessel size are small, right? In that case, the use of DCB will be of great help. So there are plenty of trials. So that showed that the use of DCB in de novo small coronary vessels trial, and there are trials, to name a few, the Restore trial, Basket Small trial, Picaletto trial, and they have showed that it has a positive outcome and it is non-inferior compared to drug-eluting stents. Same way, there are with the large coronary artery vessel trial, there are few trials at that has checked the use of DCB from right from the 9-month to 2-year, and it has a similar outcome in a few cases. It has a better outcome compared to drug-eluting stents. Again, the bifurcation lesion, right, and DCB has been compared with the simple plain balloon angioplasty, right? And of late in 2022, Liu has tested in DES in main vessel and DCB in side branches. This hybrid strategy that is superior in a 2-stent strategy, basically in terms of late lumen loss and patient and long and diffuse disease, and we have a data of almost 3 years, and it showed that there is no significant difference in TLR and MACE events, and of note that similar TLR and MACE events has been observed between DCB only and hybrid strategies. So and late lumen loss was considerably lower compared to DCB than in DES arm. And in patient with diabetes and diabetes, there are different balloons, basically drug-coated balloons like paclitaxel-coated balloon has been tested, and sirolimus-coated balloon has been tested in this subgroup of the patient, and it showed that result evidence in favor of using this technology in this subgroup of the patient. And the DCBs are basically most important in high bleeding risk patient. And it has because we know that a high bleeding risk patient has a very high mortality rates at the 3 years. And when the DCBs are compared with the DES, and there is a no difference, but DCB showed the similar rate of major bleeding in high bleeding risk patient, but lower rates in the patients who has a no high bleeding risk. And in ACS patients, there are meta-analysis. It showed that the STEMI and NSTMI patients, and there is no difference between the MACE and MACE outcomes. And DCB has showed that it is associated with lower late lumen loss. And these are the data of 1 year. And another trial has been showed that ACS, almost 50% of them were STEMI, that it has a lower rate of cardiac death and MI in DCB group. So to conclude that the potential of drug-coated balloons are it has tackling limitations of current era of DES. DCB has been potential to address the limitation of DES in various clinical and technical settings. And basically the scenarios like it is useful in large de novo coronary lesions, suitable for bifurcation lesions, whereas a diffuse CAD, right, rather than putting multiple stent, the single balloon will be of helpful. In ACS scenario, it is helpful, and in hybriding risk patients, we can use it and we can stop the dual antiplatelet very early in the course of treatment. So recent advances suggest that the last 2 years has been significant development in DCB technology and clinical data. And there are large clinical trials are ongoing, and that is following the long-term data, and that will strengthen the evidence that efficacy and safety of DCBs in these settings. So I will end my lecture by this slide. Thank you very much.
Thank you, Dr. Kinjal. So that's very encouraging data for use of DCB in non-ISR situation, which is in line with our current practices as well. Thank you so much. We'll have discussions in the end. Now I invite Dr. Hitesh Shah from Rajasthan Hospital, Ahmedabad. He is a senior consultant and associate professor of cardiology there. So he's going to compare paclitaxel versus sirolimus for DCB and how the trial data favors paclitaxel. Dr. Shah.
Yeah, good evening, everyone. Can you help me to share the slide from there, please?
Sure, sir. I'll just share it.
So, by the time the slides are shared, what I'm going to talk in a few minutes is because one patient is lying in the kettle waiting for PAMI, so I'll be very quick. Paclitaxel, the drug of choice in a drug-coated balloon or sirolimus and clinical evidence data. So, regarding the use of stent, paclitaxel stents are almost stopped now, so it is not used, but sirolimus stents are running, but it's not the case for the DCBs. Next slide, please. So drug-coated balloons have revolutionized the coronary intervention by providing an alternative to the traditional stenting, adopting the leave behind nothing approach and selecting the right drug for the coating. This balloon is critical for maximizing the clinical outcome. So two main drugs are used for this is sirolimus and paclitaxel. And clinical data of RCTs of DCBs are primarily based on the studies of paclitaxel balloon, relatively related to their favorable pharmacokinetic properties. The way you see in this slide, paclitaxel has got irreversible binding lipophilic, cytostatic drug, a strong antiproliferative action, moderate anti-inflammatory action, and moderate positive remodeling, and prolonged tissue retention and long-term stability. If you compare with the sirolimus, it's little opposite with reversible binding, hydrophilic nature, and it has less positive remodeling. Next slide. So, sirolimus versus paclitaxel for local drug delivery in vitro study, exposure of smooth muscle cells or endothelial cells to paclitaxel leads to more pronounced dose-dependent growth inhibition compared to sirolimus. Next slide. Not going into the details of the clinical studies, but it is studied wide across the spectrum of BMS ISR to the de novo lesion to the DES ISR. Next slide. Preclinical study, if you see biological difference between the three practice sectal and sirolimus coated balloon on the coronary lesion in the rabbit model, and it was shown that PCB showed significant less muscle artery ratio than SCB, indicating the high risk of embolization with SCB than PCBs. Next slide. There was one logistic regression analysis of Eastbourne and Paul multicentric study where the Percutaneous DCBs with power of study near to 500 patients and Sirolimus DCB with almost 2,000 patients, which included 900 ISR patient and rest of the de novo. And this Percutaneous arm, there was 382 ISR patient and primary endpoint was MACE at 1 year. Next slide. And there was no difference were observed in 1 year follow-up in terms of the composite clinical endpoint, either in de novo or ISR lesion. In fact, it was a statistically not a powered study because it was not a randomized comparison and limit significant variation among the two studies only partially corrected by the logistic regression models and multivariate adjustment. And the Pulse study, the impact of the lower pre-dilatation rates cannot be estimated. Next slide. Now, angiographic and angiographic derived functional assessment after DCB angioplasty for de novo coronary artery disease. That was PICO-LIGHT of 6 study, preliminary study, and the design was 220 unselected consecutive patients who underwent DCB PCI for de novo lesion and elective angiographic follow-up at 3 to 9 months and primary endpoint of left functional loss for PCB versus SCB and co-primary point was LLL. So there was PCB and SCB showed similar left functional loss and LLL with an NS trend towards a better PCB performance than SCB. Next slide. Again, the RCT Transform 1, it was compared with this Magic Touch with sequent PCB by B. Brown, de novo small coronary artery disease. And SCB failed to demonstrate non-inferiority for angiographic net lumen gain at 6 months compared to the PCB. Next slide. So treatment of coronary de novo lesion by sirolimus versus paclitaxel. One study was like first in human comparison with the novel SCB with the PCB and similar angiographic outcome in the treatment of the de novo CAD with clinically proven PCB and late luminal enlargement was more frequently observed after the PCB treatment. Next slide. So that's a spectrum where you use the PCB for de novo coronary lesion, depending on the lesion length, total occlusion target. I'm going to show this one case and we'll discuss on this part again. Next slide. So DCB angioplasty in the last coronary vessel is a future game changer. That is what has been future of the interventional cardiology because we want to avoid the metal load inside the coronaries. And if you can deal with the similar outcome with something which is not permanent, that is always welcome approach. Next slide. Next slide. So before I move on to my case, the thing is like paclitaxel DCB, not like as with the paclitaxel stent has proven the significant value as compared to sirolimus DCB. And it is non-inferiority in most of the trials and in some of the preclinical modality is superior in fact. So there are no indication that therapy could even more offer survival advantage in the longer term by avoiding the permanent implants, and the alternative of the sirolimus balloon endorsed by the many interventional cardiologists still has to prove its clinical efficacy. Now what I'm going to show is my real-time case. The patient, let me. This patient I implanted with the 3 drug-eluting stent, one in the LAD and 2 in the RCA, almost 6 years back. He was then he diagnosed with the IgG for nephropathy. He is diabetic hypertension, and recently he was on maintenance dialysis and he was getting recurrent hypertension angina during the dialysis, and that was limiting his dialysis. So we did the angiogram. It was showing RCA stent were patent, the de novo circumflex lesion, and LAD stent was occurred, and it was 100% ISR of LAD stent. Thought is what way we deal with that patient. I would like to share the video if it is. My video is visible. I am visible on my video.
It's not so
Yes,
clear. I think
we can see.
see
So
from your
I am inside the
screen.
cath lab. I want to directly show it live on the cath lab. If we can just switch on, spotlight me on my video.
Okay.
Just end the slide over there and just spotlight the video if it's possible. I am not getting. Yeah. Okay. Can you see now the cath lab images?
Yes.
The patient which I'm talking, so I would like to show it directly from the cath lab. So this is what the picture was, and this is how this LED stent was. This mid part of the stent was proximally occluded. Then, like standard procedure, crossing the wire and all imaging, everything was done, and microcatheter guided. Then it was tricky because LED was diffusely diseased. We were not like keen to stent each and every segment. So strategy was to dilate, prepare the lesion inside the stent and do the DCB in the distal part of the stent where there was a diffuse distal stenosis. This is how it looks like. Then inside the stent also the DCB was this Proteus, what we used, this paclitaxel, was in fact its primary inflation is for the one time, but they say that even you can 2-3 inflation, there is some big release can take place. So that is one advantage. So finally, we finished the angioplasty with multiple sequential steps, including the IVL and multiple cutting balloons. And finally, what I'm going to show is the result. So there was some tricky things in this patient because this patient was not amenable to surgery by any means because he was totally unfit. Circumflex was not like keen to be stent. This was looking like culprit lesion. A patient had a recent ACS also with troponin positive. And finally, with all the things, we could get the good result with including the multiple devices, including this paclitaxel coated balloon. So the thing is like this in complex cases with high risk intervention where there is a marginal patient profile in terms of dye injection as well as recurrent events. This paclitaxel balloon is giving the promising hopes where we can treat the small distal diffuse disease as well as instant restenosis in a better way. Yeah, this was the final image. Yeah, this is the final image after this distal part, and instead this was taken with the DCB, and proximally we did the stent and left the rest of the things in patient. And this is this is done 1 month back on 12th May. Patient is now doing fine. His ejection fraction is improved from 30 to near 35-40%, and he's tolerating the dialysis well without falling the blood pressure. Thank you very much.
Thank you, Dr. Shah, for your presentation, and good luck with your primary angioplasty. It's waiting for you. I hope the patient does fine. I invite Dr. Sadanandam from Sri Ramachandra Medical Center, Chennai. He's going to talk about how he is confidently expanding his DCB practice. Dr. Sadanandam.
Thank you for giving this opportunity. I know many complex cases are being discussed, but still I want to go. My topic, I made it very simple. So how confidently we have to expand drug-coated balloons practice. So first we have to understand evidence-based indications. Then we have to acquire the techniques, device selection, everything. Imaging definitely has a role. Imaging is now the main thing in many of our interventions. Build your experience and stay abreast of evolving technologies and trials. Finally, not the least, we have to document whatever results we do. So, coming to the evidence-based indications for DCBs, all associations, including American Heart Association, European Society of Cardiology, and many NICE guidelines have come with key indications for DCB. One is instant restenosis. Second thing is small vessel diseases, and definitely not the least bifurcation lesions, where you can go for a single stent strategy, and the side branch can be done with your DCBs. So emerging uses, you can see ongoing trials and studies to stay updated on evolving indication for DCBs, such as complex lesion and high-risk patients. So, for example, we have done a case for we have a series of cases which have been done in onco patients coming with a critical left main disease or a critical osteoproximal left anterior descending disease, waiting for surgery. So we have done taken such a complex cases and have done a DCBs. Even bifurcation kissing balloon DCBs has been done. And over a period of time, like 1 to 3 months, we have stopped antiplatelets and sent them for major surgeries. So those type of complex cases, we have to assess our own risk and then define the treatment for those patients. So mastering the technique and device selection, if you see, appropriate patient selection, as I told, small vessel diseases are very initial target. It should be the initial targets. Like if you are going to do the a DEB for a diagonal or a OM lesion, the success rate is going to be high, when the patency rate is going to be high with the DCB. Whereas when you compare to have larger vessel, where we have a lot of controversy still going on, but still we have one series of patients where we go ahead with a cutting balloon, create good amount of dissection up to stage 2, and without a compromise. So the movement expansions are there, and we have quite good number of follow-up up to a period of 1 year also now. And we have repeated angios to show its clinical efficiency. So individual experience varies, though the guidelines have not come with the larger vessels so far. But for, as I told, the necessary conditions where high bleeding risk or where you have to stop a dual antiplatelet drug therapy within a period of short span of 3 months. Instead of going for DES, we have done DCB for those type of large vessel diseases also. Definitely ISR, everybody will accept that even the guidelines are given first thing to go ahead with the DEBs only, drug-coated delivery. So optimizing drug-coated delivery, we know we have to develop proficiency. Some say 30 seconds, some say 60 seconds, some say 90 seconds, depending upon the unfurling of the balloon and the type of the drug being utilized, like sirolimus or paclitaxel. We have to go with the proficiency in each type of balloon drug and the balloon inflation. And we have the very important thing is, I told, the preparation of the bed for even for drug-eluting stents also. Preparation of bed is very important. So I generally take that if we go with the hyperinflation with NC balloon initially, prepare the bed very well, then only I go with the drug-coated balloon. So that makes your success more higher rate when compared to unprepared beds. So device options, stay up to date on the latest DCB technologies, including new developments in coating and balloon characteristics. I think previous speaker has spoken about sirolimus versus paclitaxel. So various things have been done. Definitely imaging is very, very important. I will say I will include FFR also, because when Antonio Colombo, who initiated all these things in our hospital, he showed FFR negativity, that is 0.8, more than 0.8 in all patients whom he demonstrated DCBs. So that was the step from where we started in our institute using of the DCBs even for large vessels. So he showed a nice dissection which didn't compromise the blood flow. The first case, what he did was osteoproximal LAD. I was shocked. Sir, I told I cannot leave my patient like that. But he told, you believe me, I am going to stay in this place only. Midnight emergency or midnight anything, you come and call me, I will come for case. So that much confident he was. And the patient, we had now 1 year follow-up angiogram. It was excellent result done by Dr. Antonio Colombo. So I always trust imaging plus physiology is very important in revascularization strategies, and especially when you are confident that the DCBs are going to be the drug of choice, treatment of choice for those patients, and don't hesitate to do imaging as well as physiology studies. So this tool helps in choosing the cases where that DCB will be more effective, reducing restenosis rate and complications. So you build your own clinical experience with the pilot cases. So start with a small vessel diseases. Start with ISR. So these are the classical cases where you can use DCBs, and so by you gain more and more confidence, then you can go for little complex lesions or bifurcation lesions where you can try your things. Generally, when I do DCBs in the initial period, I explained about the restenosis rate around 20%, and also I tell them I wish to do a check angiogram at the 9th month or 12th month. Sometimes patients agree also, and then we have proceeded with the repeat angiogram showing an excellent result. So stay abreast of evolving technologies and trials. Trials, we know cardiology is nothing but evidence-based medicine. So we have to be updated with the newer trials, newer technologies, and all those things has to be kept in our mind. The most important thing which is not being commonly practiced in India is that we do Humpty number of cases, but we don't have documentation. So that's where we are lagging. So we developed software so that we can recruit, we can collect all the DCB data and whenever needed, and we started having a registry in our hospital also. So soon you can see the publications. And that's what I will suggest all our colleagues also, or all our cardiologists also, fellow cardiologists also, develop the habit of documentation and publishing. That is going to help you for the long run. Whether it is right or wrong, only documentation and publications are going to tell us what is the future. So expanding DCB practice confidently requires a combination of clinical knowledge, patient-centered care, technical skills, and ongoing professional development. Thank you.
Thank you, Dr. Sadanandam. It was a excellent overview of how to optimize patient selection and use imaging and physiology to get the best results in patients treated with DCB. I believe Dr. Sriram is not presenting, so
Yes.
that gives us some time for discussion. So now I have a question, Dr. Ruben, or any of our experts can answer this. Now, while we know that dissections up to grade C are acceptable, particularly if there are no symptoms or ECG changes, or if you are demonstrating through physiology that there is no ischemia. But at the same time, all of us would love to finish without a dissection, isn't it? Sometimes. So, are there any? Sometimes it's a very difficult balance that you want to get a good lumen with the pre-dilatation, but then the more aggressive you go, the more likely you are going to create dissections. Are there any strategies by which you would try to minimize dissection during the lesion preparation, or you are okay, or you are happy to have dissections? Dr. Ruben, you are mute.
Yes, the problem when we have dissection, when we use DCB, is the magnitude of the dissection. But always when you put a balloon, you have a dissection, because the dissection allows that the drug introduce into the vessel wall. That is the Transform 1 study show that the paclitaxel versus sirolimus is beneficial for paclitaxel when you have dissection. So we need sometime the dissection, no more than C, but you can tolerate the dissection. And the other thing to take into account is the vessel. If you have a dissection in a proximal LID, can you hear me? No, or it's difficult. Can you hear me? Yes.
Yes.
Yes. Okay. And the other thing to take into account is when you have a dissection, for example, in the proximal LAD, I think that this is dangerous place, and maybe we are we usually sometimes put a stent in that case when we have great vessels with a great area of myocardium. So finally, we tolerate dissection, no more than C. After that, we take into account the place of the dissection. If it is a great vessel, we surely put the stent. If it is a small vessel, we did another inflation, maybe use another strategy, but we can tolerate in small vessels. And the other point of discussion in this is all this angiographic, but the Dr. Sadanandam, I don't know if it's correct, the pronunciation, use the IBUS. Sometimes when you use IBUS, you can see a lot of dissection. And in one session, I talked with Dr. Bernardo Cortez, and maybe you know him. He worked a lot with this drug, and he don't use a lot of IBUS, because if he use IBUS, maybe you put more stent, and the final result is always the same. If you have small dissection when you put a stent, or when you have dissection, small dissection, and don't put the stent. So you have to keep a balance between the magnitude of the dissection and the place of the dissection, and the final stenosis that you have. If you don't are with satisfactory results, maybe I put the stent. But if the result is quite well, I don't use a stent in that cases.
Thank you, Dr. Ruben. Now, specifically with respect to protein,
I would like to ask a question to the other panelists. I think it's very important to share the different opinion. And what is the common practice with the imaging, with the IBUS? Do you use in all patient IBUS, or maybe if you had an acceptable result, you leave the IBUS and you use only angiography?
what I do in my cases is the IVUS is typically pre, not post the predilatations. In the sense, to assess the size of the vessel and presence of calcium, calcific nodules, etc., in the initial part of the procedure. So I don't use IVUS to assess the severity of the dissection or presence of dissection, or to take the final call on whether I would stent or do DCB. So the final call on stent or DCB depends on the grade of angiographic grade of dissection and the flow and physiology and such considerations, and not by use of intravascular ultrasound.
Yes, I use. I'm talking about the final result, no, with IBUS. I agree with you that you can use IBUS for the preparation of the lesion. If it calcified, maybe you need lithotripsy or rotablate or orbital atherectomy, whatever you do, score balloon, etc. But finally, the IBUS is not always necessary, and the result with the angiographic is quite acceptable. Yes.
Yes. I have one question specifically with Protégé balloon strategy. When you use it in a diffuse lesion, when you use a same balloon for pullback, with respect to the duration of inflation with each segment. So how long do you inflate every time? If you are using one balloon for, in multiple segments within the same vessel. For the question
Okay,
from point of view of optimal delivery of the drug in each of these segments. For example, if you were to use a balloon for one segment alone, typically we would use a 90-second inflation. Now, if you were to use the same balloon in 3 segments, how do you decide on the duration of inflation in each of those segments without leading to loss of efficacy?
Okay, with the Protégé, we have the possibility of the inflation in different part of the artery. You know, of course, we can inflate in 3 segments. The time that you can inflate, of course, is less when you inflate it in 3 different places than when you inflate in one place. If you inflate in one place, it allows to penetrate more in the vessel wall, and you use more time, almost 45 seconds a minute. If you inflate 3 times in different part of the artery, I inflate it not 1 minute, less than 1 minute, maybe 30 seconds, 45 seconds, and the penetration of the drug is lower. I know. This is important to take into account because the severity of the lesion and again the place of the lesion is very important. So sometimes when you have a diffuse disease, it's better to use another balloon or a long balloon than only one balloon for several inflations.
Another consideration here is there is expected to be a significant diameter difference of the vessel over a longer lesion. For
Yes,
example, from mid LAD to distal LAD, let us say. And if there is a diameter delta, let's say the mid LAD is 3 millimeter, and in the distal LAD is, let's say, 2.5 millimeter. Is it still okay to use the same balloon for a pullback inflation? And if you are going to do that, how do you choose the diameter of the balloon? Will you choose it for the diameter of the proximal vessel or the distal reference vessel? You understood what I said? So
I write the lesion between the proximal lesion and the distal vessel because if you have a diffuse disease, sometimes it's very difficult to angiographically to calculate the size of the vessel. But we use the relationship between the vessel and the balloon 1-to-1. We prefer 1-to-1 because with this relation we avoid stenosis after the preparation of the lesion, no, of course. And then after the preparation of the lesion, we can choose the correct size of the balloon. And you ask me what I do if in different place of the artery, for example, in the proximal LID, in the middle LID, and the distal LID. Of course, there are many different sizes of the artery, and I change the balloon. I never put a 2.0 balloon in the proximal LID. Maybe that is a 3.5 almost in the proximal LID. Always to maintain that relation 1-to-1.
if you use, just for practical considerations, I'm asking now, let us say the mid LAD is 3 millimeter and the distal LAD is 2.5. Is it okay if you use a 3 millimeter balloon in the distal LAD as well at low pressures?
If we prepare, that is a very important question, no? Because if we prepare the lesion very good and the size, the correct size of the distal part of the LID is 2.5 and the proximal is 3.0, maybe you can use the balloon at low pressure in the distal part. Yes, we use it. We do that.
Okay. Thank you. Thank you so much. And I was talking about concerns about aneurysm formation in acute coronary syndromes after use of DCB. In your experience, has that been a problem like use of DCB in chronic lesions versus acute lesions? Is there any difference about long-term safety?
If I have problem like aneurysm with using DCB, that is a question.
Yes.
If we have aneurysm, no, we don't have a lot of aneurysms in long term. Maybe we don't check all the patients and they can create aneurysm, and we don't know if they had aneurysm. But in the common practice, I don't have aneurysm, a lot of aneurysm. Sometimes yes, using DCB in the vessel wall of the artery. No.
Thank you. Are there any questions from the other experts? Dr. Kinjal, do you want to ask something?
My question is that this one balloon, that we can use it in different vessels or not? If there is a lesion in LAD and LCX, so same balloon we can remove from the LAD and
Yes,
from the LCX.
yes. I use it. I use it in different artery, of course. I show. I have several slides if you can discuss in my presentation after that. But I have the example that I use, for example, in bifurcation in the right coronary artery. I use DCB. In the left main bifurcation, when it is protected with Lima, left internal mammary artery. Yes, of course, I use a lot, and especially I think that very, very useful when we have bifurcation lesions. I put the stent, then I do a kissing balloon, and then I do again a kissing balloon with a drug-elusive stent in the side branch, and not a non-compliance balloon in the main vessel. In the right coronary artery, we use many times. I think that this I don't remember exactly because I don't have the statistic in my mind, no. But I think that use more DCB in the right than in the left. I use very frequent in bifurcation. I think that is very useful because the solution or the treatment solution of bifurcation is very difficult. Maybe when you have only one stent and the final result is good, you leave it, but it's frequent that the final result is not so good, and then in that case, I put the DCB in that case. In the left main, it's not frequent, but I have a tend to use DCB, especially when we have a ramus, intermediate ramus, and the lesion in the last part of the left main. This is you have to put the stent in the LID. Maybe you have to put the stent in the circ, and you have a ramus, and that ramus sometimes we use frequently. I use a DCB. So there are many examples when I use DCB, but the answer is not always in LID. It's more frequent in the right coronary artery, and of course in the circ. So yes, in other arteries, yes.
If I interject over here, I think what Dr. Kinjal was asking, if I understood this correctly, was now when we talk about using Protégé in multiple segments, suppose you have used it in one artery, let us say in the LAD you have used one balloon, and you also need to do DCB in the circumflex, can you pull back the balloon out and reintroduce it on the circumflex wire and dilate in the circumflex? Is that what you wanted to ask?
Yes, exactly.
Yeah, because if you're
Okay.
if you are talking about dilating it in 3 segments, does that allow you to pull the balloon back and then reintroduce into another artery, the same balloon?
No, I don't do that because I think that the concentration of the drug, if you put in artery and then you put in another artery, I think that we don't know, first of all, the concentration of the artery. And in the case of Protégé, the drug is in the folding, and you inflate, and the drug is releasing into the vessel wall. And when you again, you have to retrieve the balloon and put it in another artery. No, I don't do that. I put in the same artery in 3 places, but not in other artery.
And yeah, and one more question that recently we came across a case that is a patient that was a left main to LAD disease, and circumflex lumen was 60-70%. So we have done a drug-eluting balloon to circumflex and put a stent from left main to LAD. So after putting a stent from left main to LAD, circumflex lumen was compromised, right? So we have to again recross it and balloon it, kissing balloon. So in that case, we have already done one time the drug-eluting balloon, and after doing the kissing, right, we have to do again the drug-eluting balloon or not?
You are talking, if we use the classification, the Medina classification, you are
Yeah, it was
talking in Medina
1-1-1.
classification 1-1-1.
Yeah, 1-1-1.
Yes. When the lesion is distally in the left main, in the distal part of the left main, it's more frequent that it continues in the LID. So I put a stent from the left main to LID. You know that it's better to leave only one stent than 2 stents. So provisional stenting is a strategy that you can use in the circ. You do after you put the stent in LID, you do a kissing balloon, and after that you do a pot, and then you can see the final result. If the final result is not satisfactory, maybe you can put another stent, you make a culotte or whatever you want. No? That is a strategy that they usually do in the left main when both artery and the distal part of the left main have lesions. If we don't have lesions in the circ, that is the other possibility, we use that we call a minimalist PCI, because we put the stent from the left main to the LID, for example, and without touching the circ, only one stent. We present this trial in the PCR, and we follow this patient. Sometimes has 1 year, another 6 months. And we have no serious event with that strategy. If the lesion, if the residual lesion if we don't agree with the residual lesion in the circ, this is the example, we delay the circ, and we don't agree with the final result, we use a lot of functional evaluation. We have a non-invasive evaluation. Is SFR, stenotic flow reserve, is the method that we use. And if it's not satisfactory, the physiological evaluation, and if we don't have good TIMI, and the residual stenosis is more than 30%, in that cases, we put another stent. That's how I treat the left main.
So, if we are using the drug-coated balloon in the circumflex, that has to be done as a a last kissing balloon,
Yeah.
and not before stenting the left main LAD, because if you have already done a kissing balloon of the circumflex before stenting left main LAD, and then if you lose lumen in the circumflex, and then if
Finally,
yeah,
yes,
so it has to be a final inflation. Yes.
yes, final inflation
Yeah.
with DCB.
With DCB, yeah, not before.
No, no, never, because you have to prepare the lesion, of course.
Yes.
The concept with DCB is just to deliver the drug, not to delay the lesion.
Yes.
That is the concept, no?
Are there any further questions? If there are no questions, then we will close the session. And thank you so much, Dr. Ruben, for participating in this discussion and giving your insights into your practice of treating coronary interventions with, coronary lesions with DCB, particularly paclitaxel eluting balloon, particularly Protégé. And I also thank our other expert panelists for their presentations and active participation in the discussion. And I thank Translumina for arranging this meeting. Thank you so much.
Would like to thank you all for
Thank
taking
you.
time out and enriching the session with your valuable insights. So thank you very much to everyone. And this has been really a supportive, insights for all of us to understand and learn. So thank you and have a great evening ahead.
Thank you.
Thank you.
Thank you. Thank you. Thank you for this opportunity. Bye.
Thank you.
Bye.
Bye-bye.